Good. Good afternoon, everyone, and welcome to the Palliative Care Supergroup for LMHPCO. Today is December 15th, and we are very happy to have this topic presented to folks across Louisiana and Mississippi. And with that, I'm going to let Dr. Mark Cantrow, who leads our palliative care supergroup, introduce our speaker, Dr. McMechan.
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 I'm so happy to introduce Danielle McMechan. She is a palliative care physician here in Baton Rouge and is our former fellow at LSU in Baton Rouge. And so I've had the great pleasure of working with her for the last year and a half or so. And she has graciously agreed to do this talk on de-prescribing, which is a very important aspect of what we should all be doing in palliative care and in hospice. Broad applications.
You're no longer a fellow.
No, I graduated the end of June. Yeah.
Good, congratulations. And I just want to add, Dr. McMechan, in addition to being a palliative care doc and working within hospice, she also works in the prison systems here in Louisiana. So thank you for that work as well.
Thank you. Well, thank you so much. And thank you both for that kind introduction. So yeah, de-prescribing is a very important topic. I think it's something that doesn't get enough attention until it becomes really necessary. So I think having a framework for tackling this from the beginning is important. So I have no disclosures, and as Mark and Jamie mentioned, I work for the Lake as a palliative doctor, and then for Hospice of Baton Rouge as a medical director, and then through Hospice of Baton Rouge, I do some volunteer work with the prison system as well. So just a couple of quick objectives that we're going to try and get through today, talking about end of life and different medications that come up with respect to de-prescribing, some of the more common things that we focus in on when we're looking at someone's medication list and what we might have opportunities for when it comes to de-prescribing. Barriers, of course, to successfully being able to de-prescribe some medications, and then developing a framework and process to incorporate into your own IDT. So starting with end of life and medications, and kind of first, what is the concept of de-prescribing? This is really a systematic approach to identifying different medications that patients are on and then stopping those for which harm is going to outweigh benefit. This is often done within the context of a goals of care conversation, and that's why that skill set that we have as hospice and palliative care providers becomes even more important in conversations like this. If you don't have a good idea of someone's goals, it's very hard to establish what medications are safe to consider de-prescribing. It's also important to understand their level of function and their life expectancy. Are you putting someone on hospice and having this conversation, or are you seeing them in your palliative care clinic and talking about de-prescribing? And then how functional are they? How safe is it for them to swallow some of these larger medications? Who are you having these conversations with can also be really important. The shared decision-making process can happen with patients, their families, other physicians, or some combination of those. And really, we should be doing this for anyone with any kind of life-limiting illness, or folks who are in a situation where they're experiencing polypharmacy in a way that we can try and help. So there are many different algorithms and guidelines for how to start medications. Unfortunately, there are not very many when it comes to stopping them. And so somewhere between 29 and 51% of patients are on aspirin, they're on a blood pressure medicine, a cholesterol medicine, despite the fact that they have far exceeded the time frame for any benefit from these medications, especially with limited life expectancy. Oftentimes, people are having to pay out of pocket for these medications, especially if they happen to be on hospice and it's not related to their terminal prognosis. And as I've kind of alluded to already, pill burden, of course, can lead to adverse events, whether that's a swallowing issue or just having so many different medications that you're making mistakes with respect to taking them, or some other error, missing medicines, which comes up a lot in our hospice conversations. So I'm going to go through some of the more common medications that we run through. The first one is vitamins and supplements. I'm sure you guys have all had patients on those medicines. A lot of the folks that we get on palliative or hospice services are on a multivitamin or on an iron supplement. They've got their calcium that they're taking or their vitamin D. And oftentimes what we hear from caregivers, especially when it comes to talking about stopping some of these medicines is, well, they're eating less, so they really need these medicines, or, they give her energy, or what about her bones? We need to preserve her bone function. There are a lot of great reasons to stop. And so these are some of the things that you can educate families and patients about when it comes to vitamins and supplements specifically. They can contribute to constipation and nausea, which are already very common symptoms that we see in elderly and folks with serious illness. There's often a taste or smell aversion, especially to some of these big vitamins. They can taste really bad. Some of those fish oil ones especially can taste quite unpleasant. We're not doing any labs necessarily, and so we're not adjusting any medicines. Not that that's as applicable to most vitamins and supplements, but let's say someone's on a B12 supplement or folic acid. We're not necessarily going to be checking to see if you're having a good response to that. They can interact with other medicines, especially some of the herbal medications. And then there are possibly long-term benefits for some of these things, but they're not observed in most cases. And so there's no need to taper these medicines. You can just go ahead and stop them. I will make a note when different medications come up that we should be tapering. There was an interesting study that came out last month, the 2024 Delphi study with respect to de-prescribing. And while this study surveyed a variety of practitioners, they tended to be mainly European practitioners, but I found it reassuring to know that in that 2024 Delphi study, there was 100% consensus amongst the respondents when it came to de-prescribing supplements for folks who were initiating hospice care. So that was reassuring to me that these guidelines that we're using are reflected worldwide. So next we'll talk about statins and cholesterol medicines. I think everybody's probably familiar with a lot of these. I've had patients say these things to me themselves or their caregivers. My doctor told me I was going to be on this for the rest of my life. What if I get a stroke? What if I get a heart attack? I need to be on this to prevent that from happening to me. Well, there are a lot of reasons to stop a statin. Even just dealing with things like the muscle pain itself can be a good reason to stop, especially as folks get weaker as they get older. But there's also lethargy, cognitive issues, even organ failure that these things can contribute to. And an interesting thing to keep in the back of your minds is the number needed to treat for stroke prevention is actually 125, and that's when it has been ingested for 5 years. The number needed to treat for a non-fatal heart attack is 39 when ingested for 5 years. And so, those are reasonably high. There are drug and food interactions. These really only have long-term benefits. So if you have somebody who has started on a statin a year ago and you're enrolling them in hospice, they're not going to see any benefit from that. And if they've been on it for years and years, well, they've got their benefit and it's okay to go ahead and stop. There are randomized controlled trials that show stopping statins at the end of life actually improves their quality of life. And that was primarily related to weakness associated with muscle issues. And then the National Cholesterol Education Program actually says patients with limited life expectancy from any kind of related or unrelated illness are probably not candidates for this drug therapy. Again, there's no need to taper. You can just go ahead and stop these medicines. The Delphi study did acknowledge this as well. There was 100% consensus amongst the respondents to go ahead and stop those for folks enrolling in hospice. And then even for secondary prevention of cardiovascular disease, there was a vast majority of consensus, so just about 98%. And there was no one who strongly disagreed with either of those recommendations. So I think that's also encouraging. So proton pump inhibitors, our Nexium, our Protonics, I get a lot of pushback on these. And, can't have a bleeding ulcer in your stomach. You can't have any of these acid reflux symptoms. And so a lot of folks don't want to stop these medicines. But again, there's no need to taper these. The reasons to go ahead and stop, often these are medications that are started for prophylaxis to prevent ulcers because you're going on another medicine or you had a hospitalization or, you had a brief course of steroids or something like that, and they were just never stopped. They might no longer be using that medication, like, maybe they got put on some ibuprofen and had a little stomach upset, and they're not on that ibuprofen anymore, but they are still taking their Nexium. There are lifestyle modifications, certainly, that people can do to reduce the amount of reflux that they're experiencing, encourage them to stop smoking, limit their caffeine use, their alcohol use. And if it's really necessary, you can do a short course, maybe for 14 days, but then go ahead and intentionally stop them and make sure you're having that conversation ahead of time. They can contribute to kidney injury. Of course, we are all aware of the risk of pneumonia. Your fracture risk goes up, and then the horrible idea of a hospice patient getting C. diff from being exposed to a PPI, which would be terrible. So lots of reasons to stop your PPIs. The Delphi study acknowledged these as well. There was a little bit less consensus, but still the overwhelming majority felt like if you have less than 6 months of life, it's reasonable to consider, in their mind, consider tapering. Our recommendations in the US say there's no need to taper these medications, but if possible, stop these medicines for folks who are initiating hospice care. And there was a little bit less, but still, again, a vast majority consensus to go ahead and consider tapering and stopping if you have uncomplicated esophagitis more than 8 weeks ago and you're not experiencing any symptoms. There were some that strongly disagreed with this, but again, the overwhelming majority were comfortable with tapering and or stopping. So appetite stimulants is another big one that we run into. So your cyproheptadine, megestrol, Marinol, steroids. Obviously, the concerns are pretty straightforward. They're eating less. This might help. Why not? Well, there are still plenty of reasons to stop even something like this. We expect people to eat less as they're approaching the end of their life. And if there's no improvement after, somewhere around kind of that 6 to 12 week mark, there probably isn't going to be. There are definitely unnecessary side effects for these folks to have to deal with. Drowsiness, which is going to be worsened by other medications that they're probably on anyhow, but particularly cyproheptadine can do that. The DVT risk with Megace. And then certainly the risk on your immune system with being on steroids. There is no need to taper this. You can go ahead and just take folks off with these medicines. The Delphi study didn't delve into appetite stimulants. So our cognitive enhancing agents, this is probably one of the more common ones I run into that we'd like to stop for folks, but that families give a lot of resistance to. And so that's your Namenda, Aricept, Exelon. Patients are often told by their providers this is going to improve their memory. They'll get worse if they stop these medicines, or, the concept of we're giving up. We know that nothing is going to get better, and so we're stopping these medicines. There are still great reasons to stop here. If you have a FAST score of 7 or more, there's data out there to say that these medicines are not going to help you any longer. And the American Geriatric Society actually recommends stopping as these medicines are no longer relevant for advanced dementia. The combination, some people will say, well, if the Namenda isn't working, let's do a combination medicine. I saw that on a commercial. The combination medicines are not more efficacious than either alone. There's only more side effects in this population. And the side effects are common ones that we run into in these patients, including nausea, vomiting, appetite issues, rashes, urinary retention, and a low heart rate. And often these patients that we're seeing on hospice are experiencing these symptoms anyway, and so why make that worse? Now, the tricky thing to remember with these is you should taper these medicines because withdrawal may occur. And so what I have read and what I have done in the past is about 50% a week over 2 to 4 weeks, especially after a longer term use. And so, in older patients, maybe go slow with that. NHPCO back in 2020 actually that gave some guideline cited reasons for de-prescribing, some ways to kind of initiate these conversations. And so one of the things that they mentioned that I really liked was when you're talking with the family or talking with the patient themselves, asking them, when the drug started, did you notice a change? Do you still feel like that change is there? And helping them to kind of see for themselves that this is not something that's really offering you any relief any longer. But again, if you're seeing patients with a FAST 7A or worse, if their MMSE score is less than 10, if they're terminally ill for some reason, fractures, infections, or certainly if the patient or family themselves want to stop. Those are all great reasons to stop these medicines. And then back in November when the study came out, there was, again, overwhelming consensus to de-prescribe. They specifically mentioned 3 months or less with this study. But again, the vast majority of these respondents for this study were European. And so I'm not sure how the hospice environment is different over there when it comes to 3 versus 6 months. All right, getting into blood pressure medicines, which probably could be a talk all by itself. But just very quickly, there, of course, are many, many options with respect to blood pressure medicines. People often have very valid concerns. What if I get a stroke? What if my blood pressure shoots up and I have to go to the emergency room? My doctor told me I'm going to be on this forever. Well, there are, again, great reasons to stop these medicines. That tight blood pressure control, we typically only expect for patients who are going to have a lot more time with us. If your life expectancy is short, that tight blood pressure control is no longer really necessary. And hypotension often becomes a much bigger issue as patients lose weight and they're eating quite a bit less. These medicines can contribute to falls and consequences of your blood pressure running too low. And so you can individualize this, of course, based on symptoms, based on what their goals are. You might have patients who are checking their blood pressure every single day. And so the battle might just be getting them to stop doing that quite so frequently and stop fixating on it a little bit so much. You may want to taper depending on the medicine that they're on in order to avoid a rebound hypertension effect or any rebound effect on their heart rate as well. The Delphi recommendations were pretty comprehensive, and it would actually be if you have a specific medicine and you want to have a little clearer understanding of exactly what they had recommended, it would be worth looking at the article. It's from November, but they had very comprehensive recommendations depending on the class of blood pressure medicine. And so their feeling was they recommend monitoring pretty closely, about weekly, which typically if folks are on hospice, we're doing that anyway, in the first month or so after you stop the medicine, and then monthly, or if they suddenly have a new headache or concerning symptoms. And they kind of developed an order of how they would recommend de-prescribing, starting with the centrally active antihypertensives, and then your peripheral alpha blockers, your diuretics, and of course the last one being your ACE inhibitors or your ARBs. That might be different depending on the unique situation for each patient. There were some additional recommendations. There was kind of a general consensus, go ahead and stop those beta blockers, which of course makes sense, and kind of developing some parameters for yourself. And so if you're looking at somebody who has a blood pressure under about 180 over 110, stopping the beta blockers, stopping the central acting, and the calcium channel blockers was something that pretty much everybody seemed to be very comfortable with. There was a 100% consensus, which obviously makes sense when it comes to de-prescribing diuretics if you have a situation where you have reduced fluid intake or increased loss. So somebody who's suffering from a lot of GI distress. And then, certainly if you have a patient who has, who's only on their lisinopril, let's say, for prevention of diabetic nephropathy, and they're being placed on hospice, I think that would be a reasonable time to consider de-prescribing, and again, the vast majority there as well. One thing to bear in mind, the consensus when it came to stopping beta blockers did not include atrial fibrillation. That was just with respect to heart failure without AFib or hypertension. All right, moving on to our inhalers. So obviously there are many, many inhalers that we can run into. Patients, obviously I need this for my breathing. What if something happens and I can't breathe? With respect to Hospice at Baton Rouge, this was actually in our number 6, 7, and 10 spot for our second quarter this year with respect to spending and recommendation to de-prescribe. So it does come up a lot. A lot of folks are on this. There was a 2022 study from the Journal of Palliative Medicine with 38,000 patients who were on hospice for an end-stage respiratory disease. And within the last 7 days of life, 7% had claims for inhalers, 13% in the last 14 days, 21% in the last 30 days. So a lot of people are still using these inhalers right at the end of their lives. So why do we stop or recommend to stop? Well, you need to be able to use them properly in order for them to be effective. And so you need to be mentally cognitively intact, I guess I should say, enough in order to be able to know when to push down, to know when to breathe in. They need to be able to hold their breath for 10 seconds minimum. You need to have enough strength in your body to kind of suck that powder out of the discus. And then, like I said before, enough hand-eye coordination to use the MDI effectively. You don't need to taper these, but you may want to consider having a nebulizer available for folks who do have symptomatic dyspnea or wheezing or things like that. Now, there was a note here as I was going through this, the risk of adverse effect increases without additional clinical benefit with overuse of multiple agents from the same therapeutic class. And so I've certainly run into patients who are on, multiple beta-2 agonists or multiple anticholinergics. And it's just important to bear in mind that they do have side effects themselves. And so as you increase the use of those, let's say beta-2 agonists, for example, you're going to have more anxiety, tachycardia, tremors. With the anticholinergics, more dry mouth and urinary retention. And then with the inhaled corticosteroids, more thrush and pharyngitis. So just things to bear bear in mind. NHPCO actually had some good recommendations for when it comes to having conversations about inhalers. One of the things they mentioned saying was, show me how you're using them. It's okay if you don't remember how to use them, we can go through it together. And then you can see them yourself actually trying to use it and see whether or not it's effective. There are lots of different things we can do for dyspnea management that are non-pharmacological, different positions, optimizing your environment by keeping it a little bit cooler, using a fan. There's a lot of evidence to support use of a fan. Bedside relaxation techniques, spiritual support, stop smoking if you can, and then oxygen therapy. And then, of course, we have other strategies for dyspnea management in the palliative field, including short-acting opioids or benzos, or other nebulized agents like normal saline, Lasix, and fentanyl, which I have not seen nebulized Lasix or fentanyl used myself. So, okay, so let's get into our blood thinners. So, this is pretty broad: aspirin, Plavix, Xarelto, all the way through to Coumadin. Obviously, these are, again, reasonable concerns. I might get a heart attack, a stroke, I might get a blood clot if I stop these medicines. There are definitely reasons to continue these medicines. For example, if somebody has a very low risk of bleeding, or if they have a symptomatic clot, or they're very high risk for a thromboembolism, and their PPS is 40% or greater. So that's, understanding somebody's goals, but also understanding somebody's physical situation. So again, plenty of good reasons to stop here. It's not going to relieve any symptoms. And depending on what kind of organ failure the patient might be dealing with, that would be contraindicated. Of course, your risk of bleeding is going to increase as you get older. And even multiple episodes of relatively minor bleeding can affect somebody's quality of life. If they're having to go back and forth to the emergency room, or they're having to have wounds closed up, those wounds can get infected. There are, of course, multiple drug interactions with all of these medicines, especially Coumadin. And the risk typically outweighs the benefit in patients who we expect to have less than 5 years to live. So warfarin specifically, of course, has frequent monitoring. And there's an 8% risk of a major GI bleed or intracranial hemorrhage in your elderly patients. And so that's something to keep in mind, because I know a lot of folks who insist on staying on an anticoagulant who enroll in hospice sometimes do get transitioned to warfarin because it is the cheaper option. And there are some downsides to that one as well. So again, there's no need to taper here. You could offer a trial discontinuation kind of as an adjustment period. So letting them know that you're open to starting it back if necessary, but that you want to have a trial period to see how they do and if they feel okay. And then again, these can be really difficult conversations to have with folks. And so these are just some different kind of talking points or strategies that you can do with patients or their family members. And so the first example, we would like to discuss stopping your wife's warfarin. Since she's no longer eating much, she's fallen a few times over the past month. We're worried that this medication is no longer safe for her to take. Her risk of developing a bleed in her brain or her stomach is greater than the risk of her having a stroke over that same time frame, and allowing that conversation to take place. And then the last one, because your mother is still ambulatory, adherent to medications and at low risk for bleeding, we can continue her Eliquis. And we'll go ahead and reassess and discuss when it's appropriate to stop, kind of letting them know it's okay for right now, but this is going to come up again. All right, so getting into our diabetic medications, looking at things like insulin, metformin, sulfonylureas. Hospice patients, of course, are going to experience changes, especially in their diet, that are going to affect their glucose levels. They may not necessarily show signs of a high blood sugar, but they will, of course, experience significant symptoms with respect to hypoglycemia. And they may just no longer want to inject their insulin or monitor their glucose as frequently as they need to in order to do that safely. So caregiver concerns, of course, pretty straightforward. What if I need to treat my blood sugar? How am I going to know, and what am I going to treat it with? Some of the reasons to stop, if you have somebody who has a fairly short life expectancy, tight glucose control isn't really necessary any longer. And as we mentioned before, patients are eating less and they're losing weight, and they're a lot more likely to become hypoglycemic as they approach the end of their lives. You want to avoid symptomatic blood sugar issues on either end, but especially on the hypoglycemic end. And if somebody happens to have renal dysfunction, it becomes even trickier to have them on these medicines. There's no need to taper, but of course, folks can develop ketoacidosis, and so you want to watch them really closely, encourage hydration. And this is just a table, kind of a reminder for everybody. It was a helpful reminder for me of some of the different classes of medications that we use in diabetes and who is most likely to develop hypoglycemia with respect to these medicines. All right, so bisphosphonates are Fosamax, Boniva. They're worried they're going to get a fracture if they stop these medicines, which is fair. Good reasons to stop. As we're approaching this part of our lives, we're not doing bone mineral density exams any longer. So we don't really know if these are effective. It can be hard to lie flat for 30 minutes after you take your medicines, especially if you're a heart failure patient. That can be a tricky thing to do. And ongoing treatment for 5 years with a T-score of negative 2.5 will provide ongoing benefit for 5 years. So if you've been on that medicine for 5 years, you're okay. You continue to get benefit from that even after you've stopped it. So there's no real need to continue it in our patient population. There are a lot of unpleasant side effects: heartburn, chest pain, and then jawbone necrosis, which would be a terrible thing to have to deal with. And you don't need to taper these. You can just stop them. And then there's a couple others that we run into a fair bit. Antibiotics, these ones tend to be more patient and case specific. When it comes to Hospice of Baton Rouge, just as an example, because that's where I am and where I know our practice patterns, in 2024, we have prescribed 413 different antibiotic prescriptions for 615 patients. And so these are, of course, rough numbers, but just something to be aware of. Probably doing it a lot more than we think. Psychogenic medications, these are things that we tend to put people on while they're on hospice or even in the palliative care kind of world in order to deal with things like agitation and confusion. But we need to be cognizant of, is this going to be a long-term medicine, or is this something we want for a short term? And we need to remember that black box warning for antipsychotics. They're going to contribute to falls, those different things. And then other medications, chemotherapy, HIV drugs, some of these more expensive medications tend to have limitations of their own. Okay, so what kind of barriers are we looking at with respect to this? Often patients have attachment to these chronic medications, and they associate that medicine as necessary in order for them to be healthy long-term. It was often an isolated recommendation that was made by a provider in the absence of kind of a big picture conversation about their overall health. And so they hear that isolated recommendation that I need this, and they think they need to continue to be on it for a long time. Ideally, these medicines will be talked about in the context of a larger conversation about prognosis and goals of care. But often we don't do those things, either lack of time or lack of rapport with the patient and family. And clinicians tend to fear litigation with respect to a bad clinical outcome after de-prescribing. So we worry, if I stop that Eliquis and they have a DVT, is there going to be some kind of negative fallout on me somehow? It's important to know who in a situation with patients kind of takes ownership of that de-prescribing. And I think with hospice, it's a little bit clearer as the hospice physician. But when somebody is still on palliative and thinking about de-prescribing, that can be a little bit trickier. And then you want to really monitor folks closely for any adverse withdrawal events, because that can certainly function as a barrier. If somebody starts to feel bad because they're off of their medicine, they're going to want to go back on that medicine. So watching that closely. So when do we talk about this? Well, I would say as often as we can, but certainly on admission, when you get a new patient onto your hospice service, it would be beneficial to look at their medications and see what can we talk about de-prescribing right off the bat. But each time you go to recertify that patient, I think it would be appropriate again to review their medications. Even during routine visits, if a family member is there and you want to go through medicines, that's perfectly reasonable. Anytime you're doing a family or facility care conference talking about medications. If you're thinking about reordering medications, especially those as thinking about delaying disease progression or they might no longer be effective, talk to the patient and their family about whether or not we really need to reorder these medicines. When you need to change the way somebody is getting a medicine, because let's say they've lost their ability to swallow, we should sit back and do we really need to be giving this to them under this new circumstance for them? And then, of course, if you're changing your care setting, patients moving to a nursing home or they're moving to an inpatient hospice unit, you want to think about which ones of these medications are really necessary right now. Who's going to be most at risk for having an issue? Folks with multiple medical conditions. The data says 6 or more chronic medical conditions puts people more at risk. 12 or more doses of drugs per day. So it doesn't have to be 12 or more drugs, just 12 or more doses of drugs per day. 9 or more medications. If you've had a previous adverse drug event, you're more likely to have an issue associated with polypharmacy and need to come off of some of these medicines. Low body weights and BMIs, if you're 85 or older, and if you're starting to have renal issues. Those are all folks who are at risk for an issue with medications. So some of the questions that we should be asking when we're doing these medication reviews: what is this medication treating? What are we doing with this? Why are we giving them this medicine? Does this medication support the goals that we've outlined with this patient and family? Is there consensus or is there evidence for using this medication in this particular patient population? And does the time until benefit make sense? And we're going to talk a little bit in a minute about time until benefit. But with respect to this person's life expectancy, does this medicine make sense? Do the risks outweigh the benefits? Can the patient swallow the pill or use the inhaler? And is there a cheaper alternative that we can use? Because we all understand the financial realities of a patient being on hospice. There's something to be aware of. There's 2 different concepts. First, the legacy effect. And I saw these terms as I was going through these different, the literature on with respect to de-prescribing. And so I just wanted to put out there in case anybody hears these terms. The idea of legacy effect is long-term sustained benefits after a period of treatment intervention. So we mentioned with the bisphosphonates, they have a legacy effect of you take them for 5 years, you continue to have benefit afterwards. So there's been early intervention and good control. The effect lingers after the medication is stopped, and there are cardiovascular disease trials as well to support these medicines, and that's what's included on the side. Differently, there is legacy prescribing. Legacy prescribing is the idea where medications are prescribed for someone for, that should say indeterminate duration, but wind up being continued indefinitely. And so we see this a lot with our protonics, with something like Ativan, even with our SSRIs. We do a short course to manage somebody's depression and they wind up on it for 2 years. So having really good communication up front with the patient to let them know why we're starting a medicine can be really helpful. Letting them know you really should only be on this medication for, 14 days, or this is a short-term medicine we're going to do for 6 weeks, and then we're going to reassess. That good communication will hopefully flag with the patient and their family as well that, hey, it's been 6 weeks and we haven't talked about this medicine again. And having some kind of system to flag when a course should be complete, to help reduce this legacy prescribing, these patients being on medicines kind of indefinitely when they shouldn't be. Okay, so time until benefit considerations. It's important to be aware of how long someone needs to be on something in order to get the benefit, because if you have a patient who's starting on hospice and you want to talk about initiating treatment for diabetes or having tight glycemic control, you don't have that time frame to really get any benefit. So SSRIs being used to treat depression, there's typically, we all kind of think about that 6-week lag time till benefit, somewhere in that 1 to 2 month time frame. Statins need 6 months for secondary prevention of cardiovascular disease. Finasteride needs 6 months for BPH. Your blood pressure control for primary prevention of cardiovascular disease requires 1 to 2 years of time until benefit. Statins is somewhere around 1 to 3 years for primary prevention. Having tight glycemic control to prevent microvascular complications in type 2 diabetes requires 8 to 10 years of time until benefit. And then the recommended time until benefit for colon and breast cancer screening is 10 years. And I mentioned that because I have been asked by different family members why hospice patients are not getting mammograms and colonoscopies. So that can be a helpful tip. All right, so how to implement this in your own IDT. So some of the best practices that are recommended are having a process for medication reviews and discussing that openly with the patients and families throughout admission, so being upfront with what they can expect, providing reasons why you're making these recommendations and not just telling them, we have to do this, we're going to go ahead and cross all these different medicines off this list. Establishing trust can be really helpful. It's hard to do things that the patients and their families are going to find kind of scary, like stopping some of these medicines, if you haven't built a good rapport with them. And then looking at this as a process, you're not going to go in there on day one and get rid of all of the medicines that you might think are appropriate for de-prescribing, but rather it's going to be an ongoing conversation. We're going to talk about some positive language that can be helpful. And then it can also be nice to offer choices rather than just, demands, to offer choices when you're making your recommendations. So we'll go through some of these. There are a couple of different frameworks that are available for de-prescribing. The Holmes model is one of the ones that was mentioned a little bit more frequently. You want to identify patient-specific factors, and we've talked about these things, goals of care for that patient and their family, and what is their prognosis, and then look at the medication specifically, and what is the treatment target, what are we trying to accomplish, and how much time is necessary until we get a benefit. There's also the Garfinkel de-prescribing algorithm, and NHPCO advocates for this. And it basically just goes through with each medication and kind of asks you yes or no questions to get you to a place where either you stop the medicine, reduce the dose, or continue that same dosing rate. So that can be helpful to walk through with your medications that you're wondering about. FRAME is another acronym that is recommended when it comes to de-prescribing conversations. And acronyms are not always successful for me, but if these work for you, FRAME is a good one. So F, of course, fortify trust. You have to do that no matter what kind of conversation you're trying to have with folks, especially on hospice. Recognize their willingness or their barriers. Where are they open and where are they, pretty closed off when it comes to this idea? Try and align with them as much as you can with respect to their goals of care. So reminding them, hey, you said you wanted to be, at home and comfortable and not taking 20 medicines when we got to this place in your life, and we're on an awful lot of medicines. How can we maybe modify that? Managing cognitive dissonance, trying to not get stuck in one of those cognitive traps for anybody who's done the Vital Talk training, trying not to get caught in any of that, but really going back to, what are your goals and why is this important? And then empowering patients in their conversations. We don't have to decide these things today. You guys talk about this. This is going to be an ongoing conversation that we're going to have. Build is another model. This is the folks who do the fast facts with PC now. They advocate for the build model, and it's very similar. Build a foundation of trust and respect. Understand what the family wants to know. Inform them about what's important with respect to evidence. Listen to their goals and their expectations. Maybe they were not appropriately informed about what hospice is, and they're really surprised that this is even coming up as a conversation. And, developing a plan. How can we sit together and figure out how we can do this best for the patient together? So what to say, what not to say. Best not to use phrases like, well, we don't have a choice, or you must do this. We're not going to provide it because it's not on our formulary, or it's our policy. We don't have anybody on this. Certainly telling them it's too expensive. It's never a good idea. Or, the doctor says we have to do this. That's not going to work. Instead, let's explore this alternative. Let's try and optimize the situation. Let's reduce harm for this patient, or let's lessen their pill burden and try and make it sound a little more positive thing that you're doing for them. So some sample phrases, talking about trials and drug holidays. And if there are concerns, we can always pause our taper or restart a medicine. And just acknowledging, hey, our goal was really to be comfortable, but it seems like this medicine is causing more problems, and bring them in. Are you seeing this too? We're seeing this, but are you seeing it as well? So going through the actual process itself, if you have a pharmacist that you can pull into these conversations, that's ideal, but certainly not always available. If you can't do that, you as a team, considering their goals and prognosis, risk of harm, thinking about age and the number of medicines that they happen to be on, assessing each medication for what the risk benefit is and the treatment target, and then discontinuing medicines based on priority. If you have a patient who's coming in who's not able to eat anything anymore and they're still on insulin, that would probably take priority for me in order to avoid some negative side effects. And then monitoring them for any potential adverse drug withdrawal events. So in your IDT, pick a framework that you like, and then we try to choose just a few patients each week, new admissions, anybody who's being recertified, or if we have, one nurse in particular who really wants to go through all of her medications or all of their medications in order to avoid it getting overwhelming, because it can be a lot. And know that this is not all going to happen overnight or in one meeting. It's going to be an ongoing thing. I also encourage the whole team to be part of this conversation, because I may think it's reasonable to stop a medicine, but the aide who goes out may know something that I don't know. And so encouraging the whole team to participate in this conversation is really important. And so something to remember, of course, every prescription needs a diagnosis, but not every diagnosis requires a prescription. So a little mantra to have in the back of your mind. These are some of the resources I found out there for folks who are wanting to do a little bit more with de-prescribing. NHPCO has some really helpful statements. De-prescribing.org has some really good algorithms and videos. There's an advisory group called the NSW Therapeutic Advisory Group. It's a little less comprehensive, but they also had some really helpful resources. ePrognosis is the UCSF time to benefit calculator, one of the calculators that they have on there. And so you could go on there and plug in somebody's information and see what kind of time they require until they get benefit from a medicine. The anticholinergic burden calculator, there are a lot of elderly patients who wind up on anticholinergics, which can cause a lot of problems. There's the Beers list, of course, and then MedStopper is another online resource that you can use. And these are some of my references. And that's it.
Thank you, Danny. I thought that was great.
Thank you.
And I think it really underscores that idea that this is an ongoing conversation and not a one-off. You know, we get that question a lot of times when we are referring patients to hospice from the hospital as part of the palliative care team. Are they just going to stop everything? And, you know, sort of having a framework of communication to discuss all those things is really helpful. And it also falls in the same category of like things hospices don't do. Like we don't do IV fluids, we don't do physical therapy. And so, you know, I generally have that conversation with families or, you know, sometimes the patient that hospices will do any treatment. Any treatment is possible if it will help someone feel better. And so let's go through, you know, so even if you're talking about IV fluids, you know, when could that possibly be helpful? When is it not going to be helpful? Same thing with the medicine. Let's go through the medicines and talk about each one. Is this still a helpful medicine? If it is, we're definitely going to continue it. If it makes your heart failure feel better, but if it's not, let's talk about discontinuing it. And when you set it up in that framework, just like you said, you know, it really creates a lot of buy-in and alignment with the patients and families, and you're not just stopping everything, which you know, really creates a negative experience for a lot of people. Falls in that, yeah. So perfect. What do you recommend? Let me have a question for you too, besides that lengthy comment. What do you do for patients who come in and they are on inhalers that cost like $1,400 a month? What do the studies show about, you know, what we should do with that?
So I think the biggest takeaway I got from inhalers and doing all of this is people probably, especially as they're getting older and weaker, aren't using them correctly anyway. And so, you know, going out there and I think that's something that we often miss in the hospice experience, especially as I'm not going out there as much as I wish I was, and going out to their house and saying, you know, hey, show me how you use your inhaler. Like, go ahead and do it for me. And I watch them and really absorb what they're doing. And then have a conversation with them about, you know, hey, you're on this medicine, without necessarily saying it's this $1,400 inhaler that you're using, but you know, it seems like it's not really working that well for you anymore, or your hands are too weak to squeeze it like you need to, or your chest is too weak to suck up the medicine like you need to. How would you feel about trying a nebulizer, which is cheaper and might even be more effective for folks who are not able to, you know, suck up that medicine the way they need to now at this stage in their life? And so really having that conversation with them about, I think this would be more beneficial. Would you agree to try it with me for 2 weeks and see if it feels as good or hopefully better as your inhaler? That's kind of what I have tried in the past with folks.
Yeah, and people like equipment in some instances. They feel like they're getting a better treatment when they have, you know, some equipment. And you know, as you said, often when people near the end of their life, those very expensive medications that might have provided some nuanced benefit earlier in their illness now really isn't offering a whole lot. But it's really hard to sometimes pry the fingers of the patients and families off those medicines, you know.
Oh,
Yeah,
yes, definitely. And we have done, you know, where we'll try and find a cheaper alternative inhaler if folks are really insistent on sticking with an inhaler. But so far, I think I've only had 1 or 2 people say to me, oh no, I'm absolutely not going to try a nebulizer for whatever reason. Most people are pretty happy to have something like that. They think it's helping.
Yeah, and sometimes you can even enlist the pulmonologist who's, they've referred the patient to help. I've done that before too, and they said, well, no, my pulmonologist, my lung specialist recommended this medicine,
Yeah, that's a great idea. Pulling other physicians in, and that's not something I talked about as much as I could have in this conversation, but I think that's pulling in their primary care provider or whoever happened to prescribe that medicine originally, getting them on the phone and, hey, would you be willing to have a little speakerphone conversation with this patient and I about this medicine and how it's okay to stop your Boniva at 90 years old when you're on hospice for any reason.
Right. Thank you.
Thank you. Any other questions or comments or anything?
I'm just wondering if anyone that's on today's call has any questions for Dr. Danielle.
Well, thank you for having me. This was great.
Thank you for being had. It's always interesting.
And Jamie, when's our next talk?
That's what I was going to get ready to say. We have our next palliative care discussion on Tuesday, January 14th, same time, same station. It's going to be respectful care, culture, and spirituality.
And then Angela in the chat said, excellent. Where can we download slides? When and where will the recording be available?
That will be posted on the palliative care page of our website. The video will probably be posted later on this afternoon. It takes a little while to process. And Dr. McMechan, when you send me your slides, I will also post them right next to the video as well.
Sure.
On that same page. On our website, you just go for professional resources, and then you're going to see palliative care. Click there, and you will see all of the recordings that we've been doing in terms of the Supergroup.
Great.
Any other questions from the peanut gallery before we call it a day? Well, again, I want to thank you all for your attention and for the information that you've been presenting, Dr. Danny. Look forward to seeing you next time we're in person together.
That's great. Bye, everyone.
Bye, everybody.